Hi there, everyone. Nice to see you. I see everyone's trickling in, so we'll give it another few moments, but we're glad to have you. Welcome. Good morning, everyone. Yes, I see we have people from New Jersey, Maryland, Pennsylvania. It's so nice to see you all. Thank you. A few people from Florida. I'm in Florida too today. It's nice to see you. Toronto, DC, New Jersey, Virginia, West Virginia, Fort Myers, all over the states. Glad to have you. We're going to give it just another minute while we have a few others trickling in, and then we'll get started. Greetings from misty Atlanta. Yes, even in South Florida, it's a little humid down here, so I can relate. All right, well, we will go ahead and get started. It fills my heart to see everyone chatting in the box and sharing where you're from. I love that Karen welcomes everybody from across the US as far as Washington State. I saw that on here, and Fort Lauderdale, which is right here in my backyard. So welcome everybody. So if we have not had the chance to meet yet, my name is Amanda Bassos, and I am the Regional Resource Director for South Florida for Karen Treatment Centers. And again, I want to thank you all for joining today's webinar topic on trauma-informed and resilience-oriented care, a foundation for well-being and recovery. Few housekeeping things before we get started. As a reminder, we are conducting today's session in a webinar format. So all of your microphones are muted the entire time. While we can't see and hear you, you can see and hear us. And during the presentation, feel free to use the Q&A box like many of you are right now, the chat box, ask us questions. Depending on the volume of questions at the end, we may or may not be able to get to everything in live time, but don't let that stop you from asking a question. Please put it in there. We will save all the information and within a week be able to get back to you in an email or a phone call and give you the answer to your question. So today's presentation is eligible for 1 CE credit, and we'd like to thank our educational partner at CE Learning Systems for helping and providing these credits through co-sponsorship with the American Psychological Association. Now, note that in order to receive your credits, you have to stay on for the entirety of the webinar and complete the post-webinar evaluation. So right after this session ends, a link will be emailed to you directly from cego.com. You'll fill that out, and then you'll have immediate access to your certificate of completion. If there's any issues with that, again, don't hesitate to reach out. We're happy to help. So today, I am proud to introduce our presenter, Dr. Maggie Tipton. And she has a very long bio, so I'm excited to introduce her here. She is the Senior Director of Psychological Services and the Corporate Coordinator of Trauma-Informed Care at Karen. Dr. Tipton provides leadership in the development and implementation of new psychological services, and she oversees a psychology department of 10 staff psychologists and fellows. She also maintains responsibility for Karen becoming a trauma-informed organization. Dr. Tipton provides education and training on evidence-based practices for Karen, as well as in the community, to ensure the highest standard of care for patients in the Karen continuum and as they transfer to a different level of care. She is skillful in integrating psychology and 12-step recovery, focusing on those aspects of mood, personality, and relationships interfering with an individual's recovery process. She earned provider status as a cognitive processing therapist in 2018, and she is trained in EMDR. Dr. Tipton is licensed in Pennsylvania and earned her Doctor of Clinical Psychology and a master's degree in psychology from Marywood University in Scranton, PA. She earned an advanced training in traumatic stress certificate from the International Society for Traumatic Stress Studies. So we're in for a treat today, I am sure. I will now hand the presentation over to Dr. Tipton to get us started. Thank you in advance, Dr. Tipton. We're excited to learn from you today.
Thank you for the introduction, and I appreciate everybody joining us, and I hope that you'll find this to be maybe one thing you'll take away that you maybe didn't think about before. It was a really difficult presentation to put together. I think part of it is because it's such a passion of mine, and the other part of it is there's just so much information. So I hope you'll kind of bear with me. There might be some things that I move through very quickly, and I guess I get that opportunity because I'm facilitating it. But if there are questions that come through or something that's on a slide that I did rush through, by all means, take a look and then ask any questions or email any questions, and we'll make sure you get what you need from this training. So I guess that's my really kind of long-winded way of saying, I want you to get something out of this. So take whatever you can from it. And if you have questions, reach out. I'm not going to go through the learning objectives. They were already linked to the presentation. And I think what you'll find is I don't go through sequentially of my learning objectives. I like to try to thread these things throughout. So I hope by the end of this, and if I don't, please make sure you note it in the evaluation. But I hope that I get through all of these in some way, shape, or form. Really quickly, kind of just, we can't talk about trauma-informed without really looking at what is trauma. And I think SAMHSA did the best job, even though it was 2012, 10 years later, I think this is really one of the best and most accessible definitions of trauma. So really looking at an event or a series of events that are experienced, right? So these three E's: event, experienced by an individual is overwhelming or life-changing and has a profound effect on their psychological development, well-being, interfering with certain areas of aspects of their life. And I really love the idea of looking at the impact of trauma more so than the definition when we think about trauma-informed, right? Because what we want to consider is that trauma ultimately impacts the way people perceive things. It shapes beliefs. And so if we look at that image to the right, you could see where it's really lush, there's water. And, that's what maybe, I might see in a situation. In that same situation, somebody else who maybe has had some pretty significant adverse experience as well as trauma might see to the right, really dry, not a lot of life. And so if we think about how that colors the way that people relate, not only to their world, but to us, it then helps us to ask a question in a different way. This is a lot of my slides are going to be overwhelming, and I apologize if there's too much. I think this one's a really great picture, and I won't say everything, but think about, these are just some of the things that might show up in a room related to trauma. And as we talk through this, we're going to be talking about trauma doesn't just show up in our settings with patients. It can be with other staff members, with referents, with consultants, with vendors, all of those things. So if you really consider that and all that could be showing up, there's really good reason for us to prioritize consideration of how people are showing up for us, and sometimes what that may look like and how to reflect on it differently. The landmark ACEs study, I'm sure that everyone in this presentation or attending has had some training in this. And the reality is we could do a whole hour just on ACEs, and we're not going to do that today. But I really wanted to pull out a few of the key statistics. So 1 in 3 adults have had at least one adverse experience in their life. So I think about this as, even if you're working out of a very small private practice with 3 staff, it's likely that one of them has been impacted, right? And if you have, let's say 6, I know this isn't realistic, but 6 patients among the 3 of you, we know that at least 2 of them. So if you think about that, it starts to increase the likelihood that you are not only going to come in contact with somebody who's had an adverse experience, but it's also going to impact the likelihood that it's going to be important to react to them in a way that takes that into consideration. 1 in 6 adults have had at least 4 adverse experiences. Again, we could keep going, right? You got 12 staff, 2 of those individuals, you have what, so on and so forth. At least 5 of the top leading causes of death are associated with the ACEs. So it starts to really help us understand why it's so important to not only treat trauma effectively, but also work within the scope of being trauma informed. And individuals who experienced 5 or more adverse experiences are 7 to 10 times more likely to report illegal drug use or addiction. And that's really a priority at care. And we treat co-occurring issues, but everybody has a primary substance use issue. And we see a lot of patients who have had some history of trauma or adverse experiences showing up at our doors. And I will reiterate this multiple times because I really want to drive home how people show up, right? The likely patients, but it's also our staff, our colleagues, the family members of the patients that we work with, the consultants, the vendors, and so on and so forth. You can come up with many more. And this is just an extensive list of some of the outcomes linked to ACEs. And there's a lot on here. I think that there are several related to relationships. And as we think about kind of a paradigm shift to connection and how that can buffer against the long-term impact of trauma, you see things like multiple divorces, sexual acting out, intimate partner violence, and work-related problems, right? So there's so many on there and all of them are significant. And I just want to pull your attention to some of those more relational ones as we keep moving forward. So if we take all of that into consideration, right, that, people are showing up in a variety of ways, that at least one in 3 have had potentially or 1 adverse experience, 1 in 6 have had 4 or more. Again, it just keeps speaking to the need for organizations to become more trauma informed. And this is one of those slides that, like, when I read it, I go, wow, like, so true, right? If the chicken came to the pig and was asking about opening a restaurant and said, like, hey, do you want to do it? We're going to call it Ham and Eggs. The pig really kept no thanks, because they'd have to commit, right? Like, there's a commitment there. Whereas the chicken would be involved. So always remember the distinction between contribution and commitment. The matter of bacon and eggs. The chicken makes a contribution, the pig makes a commitment. And I share this with you because you can really approach becoming trauma informed or being more trauma informed in small bits or in a huge, consultation, change process. And however you do that, it's going to take contribution. Commitment. It's going to take everyone that gets involved in that change process to be willing to show up, to be willing to ask the hard questions, to collaborate, to have the discussions, to bring some of those discussions to leadership teams. It's no easy experience. And, I think it's worth it and it's necessary given what we've already gone through related to how much trauma is out there, how it shows up, and all the ways that it can show up. So let's just talk about what it is, what a trauma-informed approach is. And I think it's really important here to consider, like, you could be trauma aware and maybe, you have certain of these R's, and, wherever we start, that's perfect, right? Like, it's a start, but how being trauma informed really includes all 4 of these R's. So we realize the widespread impact of trauma. So again, this is like what we're starting to use as kind of our just like the 4 R's are really like the frame of reference that we're going to be using to consider for every single way that we show up and interact, right? So we realize the widespread impact, we recognize the signs and symptoms, and we respond, integrating knowledge about trauma into everything. And I think that we're really good at times around doing this for our patients. We also can be really good at doing this as far as evidence-based treatment and, different interventions. But this takes it a step further. And I don't think I realized just how daunting that can feel until we were kind of smack in the middle of starting or maybe not smack in the middle, but starting our consultation process at Karen through the National Council for Mental Wellbeing, and realizing like, no, this is like an overhaul of policies, of procedures, of job descriptions, like everything you could think of is a part of it. And I don't want that to set you off, because I want to talk about how this can be small, like it can happen incrementally, and it has to, otherwise it's not going to be long lasting. But it really is somewhat daunting at first glance, and likely why sometimes people kind of stop at some point during the process, because it feels like too much. And nonetheless, it's absolutely imperative. And then the other is resist re-traumatization. And I think we could think about that from the patients that we see, from the people who have been through some of these adverse experiences. But if we could, I know some of my colleagues have struggled with that concept of trauma among each other, right? I'm not going to get that deep. I'm not going to delve that deeply into some of my staff backgrounds. But sometimes it's not trauma. Sometimes it's an adverse experience that doesn't rise to the level of what SAMHSA gave as the definition in what I shared earlier. Sometimes it's literally like, I have a backstory. Each one of us does. We have our own unique history. It can involve culture. It can involve gender. It can involve stress, adversity. It can involve, like this morning, just having a hard time getting my kids to school, right? And all of those things are ways that I then show up. And one of the things that we want to do is on both sides of it, right? So we want to actively work from a position of resisting re-traumatization. We also want to recognize that at times we may have interactions with each other, our colleagues, even with our patients, that don't go as well as we would have liked, and creating an environment that it's okay for that person to come back and say that, or it's okay for me to approach that person and say, look, I wasn't, firing at all cylinders yesterday due to A, B, and C, and can we have a conversation about like how that impacted you? And let's be honest, there's never been a time in, someone's trauma history where the perpetrator said, let's talk about how this impacted you, like, or maybe, but not like that's not the norm. So even that just begins to resist that re-traumatization and correct an experience that maybe in the past was not so, it was awful. This slide makes me laugh. My first thought is the road to trauma-informed, resilience-oriented care. I'm going to call it TIROC moving forward, because if I do not, I will spend more time saying that acronym than I will actually be able to talk about those slides. So the road is paved with tears, frustration, excitement, just like so many, like just the feeling of accomplishment, right? And it's just starting. I think of, and I would say that most people who probably start this initiative, you realize you're not walking into something that's going to be like done. There's no ending to it. And then you really realize that there's no ending to it, right? That it's going to be a living process, that every day, every week, every month, every year, you are going to be looking at like checks and balances, right? What are we doing well? What are we not doing well? Karen had the luxury of working with a consultant, and we had developed a team of people who became the core implementation team, the team that was really taking information that we received through organizational assessment and determining where do we need to prioritize, and ultimately what are some of the areas that we're doing quite well in, and let's celebrate those. So we look at things like assessment, screening, like the first time somebody interacts with a patient interacts with a staff member, admissions, what does that look like as far as those screening questions? We're considering, again, like the first time somebody calls in about a job or, comes in for an interview, like how can we make sure that we are taking into consideration all of these aspects of being trauma informed, but also preparing people. One of the things that makes me chuckle from time to time is how often we just assume that people know something. We do it with the patients that we treat, we do it with the staff, we do it with the families. And then there's this level of frustration when it feels like they should know and they don't. And you know, I had a doctor's appointment recently where, and it was endodontist. So like, I'm not kidding. This group was, I don't know whether they think they know it's trauma informed, but the way that they prepared me for the procedure, and then they prepared me for what comes next, was incredible. And so that's kind of what we're thinking about all the time. Like, how do we prepare people effectively so they kind of know what's coming? And if they don't know what's coming, we've done something wrong. The other thing is really looking at, like I said, the policies and procedures. And our care, right? We want to be doing evidence-based treatment that has really been shown to effectively treat those individuals with trauma-related disorders. And a lot of the research that I was seeing around this, especially related to buy-in, so it was that you really have to have your leadership involved. You know, there has to be buy-in. And some of those studies showed that when the leaders were actively involved in the process, the staff that were working within that department were more likely to buy into the trainings, right? Because part of the trauma-informed care model is that everyone in the organization is familiar with ACEs, is familiar that, you know, there's the potential that people have experienced this and at what rate that familiarity it is, and then kind of like how that would show up and how might I respond. So, you know, just kind of thinking through however a process is taken on, it's really kind of getting some key influencers and leadership involved to get more people in the organization to buy in. And it was really funny. You know, I think Karen is an exceptional place in a lot of ways. And it was hard initially to even kind of see the buy-in, right? Like I knew people were excited and open and motivated. But it's kind of like, you know, there's something that's out there that's being talked about, but never really hear it like in a meeting. And the first time I actually heard something about trauma-informed and workforce and all those pieces in a meeting, I was just like, you know, you can use those little emojis in WebEx and just like a total like applaud moment. And again, that's where it can be frustrating, but you have to remember that change takes time. The effect, while the change is happening, the effect can take some time. And so just really being okay with a natural progression as long as there's a commitment to it. So these principles of a trauma-informed approach are really run kind of throughout all literature. And so here's where I'll start to try to explain, like, okay, so maybe you can't, you know, take on every policy and procedure, however that looks for where you work. But maybe you can start to just kind of think about these principles: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues. Like maybe you could just take into consideration how they're showing up in parts of where you work. How they're showing up in the way that people are treated, right? Not like just our patients, but throughout the places that you work. And I'm going to go through these one by one. So safety, you know, Bloom's quote, "A physically safe environment, although necessary, was not sufficient," I think is so important, right? Because you know, we can define safety in so many ways. So it was actually then termed as not only the physical safety, but the psychological safety, social safety, and moral safety. And wow, that's pretty hard to see down over there with that psychological. So I'm going to read a little bit from that. But thinking about moral safety, like just having trust, integrity, honesty, like what, you know, how do we maintain that? Social safety, I mean, frankly, wherever we can have naturally occurring healing environments is going to be imperative. For corrective experience, for recovery, because, you know, we just have been coming, and hopefully, you know, who knows where we actually are in the whole process, but think about the last 2 years. I mean, there's been a cumulative source of stress for everyone. You know, we, like Amanda said, we have people who from Washington State to, you know, New Jersey and down to Florida. And frankly, like everyone has had some degree of stress and duress over the last year related to COVID, but lots of other issues that have been going on. And so the number of traumatized, like the volume of people who need care is likely going to far exceed those treaters. So where we can have those naturally occurring healing environments, that's great. The psychological safety piece, again, I think, this is important to patient care, but as we begin to think about kind of how systems, how organizations, how workplaces function, teams function, psychological danger. So when there's a perceived like kind of psychological threat within a system, there's usually a fear of making mistakes, a tendency to blame others, less likely to share different views, and there becomes this groupthink. And I would say in the context of that, like this common knowledge kind of practice, you actually don't see growth, right? Because groupthink happens and we pretty much stay stagnant and think that like, hey, what we're doing is working, let's stay with it, right? Whereas with psychological safety, there's comfort in admitting mistakes, right? Isn't it nice when you can say like, I don't think I did that very well, right? Maybe I'll be asking that at the end of this presentation. Learning from failure, like learning from challenging situations, adversity, or times you just didn't do so well at something. And everyone openly shares ideas. So there's better innovation, there's curiosity, and there's growth. And if if I had to lean to where I want to be, like I totally want to be in that psychological safety thing. And here's something that's really interesting. I don't think Karen sometimes thinks about it as like really remarkable, but one of the things, and I think anyone could put this into their own practice, is during that discharge, so patients complete an exit, kind of a discharge survey. And one of the questions on there is, I felt safe. We don't ask physical safety, psychological, we just ask them their experience of felt safety. And I would say, I might be wrong for today, but I know the last time I looked into this, that right around 90% or 90% plus of our patients felt safe, right? And so I think that would be such an easy way to begin to tune yourself to organizational safety, like within your teams with your colleagues, but also within the care setting. The next one is trustworthiness and transparency. And I think these go hand in hand, right? If people have practice candor, if people practice being transparent, like they're more trustworthy. And some of the ways that trust gets improved upon or people become more trustworthy is integrity, sincerity, reliability, consistency, commitment, and competence. And in some ways, you might consider, again, as you think about how you in your own practice alone, or you in whatever way you work, right? Whether it's with a large team, with a small team, how you might be able to develop some expectations for yourself or for everyone that works together to live in a way that kind of fits with this. And some of that might be related to integrity, doing what I say I'm going to do, right? Commitment. So even just being able to pull out pieces like that can be really helpful. And I know I said, one of my learning objectives was related to a paradigm shift to connection. And I also said, when we look at those outcomes around ACEs, like some of the impact it has, there were things like divorce, work relationships, all of these pieces that are truly relational and really important to focus on. Then how do we correct experiences? Some of the treatment that we do from time to time is really more, especially in level 1, a safety stabilization approach to treatment. Part of that is shared experience. Part of it is coming together as a patient who has experienced a traumatic event or traumatic events, and realizing like they're not the only one, because trauma can have such an isolating effect on people, and it can, in that isolation, the meaning that they came to be as a result of the trauma, right? I'm bad, worthless, I can't trust anyone. Those types of that type of thinking just continues to get ingrained. And actually, I would say it gets fuel added to it, and it just keeps getting bigger and bigger. And so, there's opportunity with patients and that peer support. But I think there's also opportunity as we think about each other, whether it's in consultation groups, whether it's in supervision, whether it's, finding ways to receive and give support at any aspect of the organization, how that would counter some of the ways that not only trauma can affect people, but also how it can affect the work environment. Collaboration. So collaboration and mutuality, these images are perfect, right? So the one this is, these two people sitting together, they look like they're working together. And on the other side of that, it's not, me kind of standing over someone or this person standing over someone and talking at them or down to them. And again, we don't know what the context of their conversation is, but I just think it's a nice image to look at it. One of the best things that you could think about is, how, again, and that psychological safety is probably imperative for this to work, but being able to bring a group of people together to discuss any topic, whether it's related to trauma or not, and brainstorm and really recognize that while there might be a natural hierarchy in a system, how do we kind of try to take that out of this particular conversation, whatever we're talking about, in order to ensure that everybody recognizes that their opinion is just as important as anyone else's in the room. And I'm going to pick a little bit on the chief executives of the world, right? So, they could be as collaborative, they could be as friendly, they could be as open and, like collegial as possible, but just that title, right? Chief executive lends itself to this sense of power differential, right? It might not be the way that they see themselves, but it might actually still be experienced in the room. So even talking about it, like really trying to talk about what's the elephant in the room is that, it might be kind of weird for so-and-so to be showing up as the chief executive. And I want to let you know that I think that we're all, similarly important to this process. And, by me continuing to show up and engaging at this level and collaborating, that you'll see, the mutuality that we're hoping that, I'm trying to convey right now, right? So how do you then bring into the conversation the thing that might be like the thing that nobody wants to point out or talk about? I think that that's a huge part of collaboration. Another principle is empowerment, voice, and choice. And, again, I think we could see why this works. So I want to give you a little bit of a tool, which I thought was really helpful. So when we took on the process, it started at Karam, we did an organizational self-assessment. It was lengthy and it was a lot of information, and it yielded great results of like I said, areas of strength and areas of growth. But one of the things that I found so much more helpful was this information. So what do we need to keep doing to be trauma informed? What do we need to change doing to be trauma informed? What do we need to start doing to be trauma informed? And what do we need to stop doing to be trauma informed? And what's funny is the first time we did the assessment, there was definitely write-ins around all of these and a lot of valuable information, but it like quadrupled like in the next, the volume. So we did it before a beginning and an end organizational self-assessment, same exact measure. And we had these, and the write-in responses were like phenomenal. So I think part of that said to me, like, people realize that they have a voice, right? And they're feeling like we're giving them the opportunity to share it. And they took the opportunity. And some of the things that were great were sometimes we're trying to take tasks off of our staff plate. But sometimes we don't know what they would want removed, right? So a lot of times we'll say things like, gosh, they've got so much going on. I don't know that they could do another training. But what the staff said, this is all levels of staff from everyone, clinical, non-clinical, and people really did just describe training, right? When training is meaningful and it helps me do my job better, it makes me feel more competent, and I value that, right? And sometimes it's really like changing. A thing that we heard frequently was when you think about the volume of patients and acuity, like can we be really thoughtful around the volume of patients and acuity, because it has it taxes the staff over time, and it can make it really hard for them to feel as though they're doing what they'd like to be able to do for the people that they care for, as well as the teams that they work among. So again, just as you kind of go through this, and you'll get these slides, that's another one that I think would be a very simple addition to a supervision, a little assessment of your place of work, or you yourself, if it's more private practice, to just explore kind of where you are with being trauma informed. And then, last but certainly not least is cultural, historical, and gender issues, really being open to, I don't know much of anything about some things, and other people really do. They've experienced, this is another part of the story that they bring to either treatment, their career, all these pieces. And how do I stay responsive? How do I stay curious, open, and even willing to make changes when someone calls my attention to something that we're not doing particularly well? So that's a lot. All those principles are a lot. And, I think, it's hard sometimes to think about, like, yeah, it's a huge task. But how could we start to do some of this in our daily work? And again, I bring this back up because this will show up, like, trauma shows up in so many ways. And it's so important to consider that, not, again, for everyone that's involved. I love this. This image, this like cartoon is great, right? It really shows that we all come from different life experiences. We all come from unique perspectives, and we want to be talking and asking about those vantage points, because it could be really easy for the guy in the back who's saying it's a rope, when the guy that's at the wall says, hey, what do you see? And he says it's a rope, and the guy, no, it's the wall, a wall. Like, there's that raises conflict. Whereas, all right, well, what do you see, right? Like, what is your perspective? How has this, like, what is going on here? And just trying to talk less, listen more. And as like a recovering perfectionist, sometimes listen to understand, not respond. It's totally my stuff, but it can be really challenging, because I don't want people to realize I'm in the imposter, right? That I sometimes fear that I am. So I'm almost preparing for a response so I can sound like I'm smart, and I've totally stopped listening to really understand what's going on. So being really open, curious, what has happened to you versus what's wrong with you, what happened throughout today. You could apply those questions to anyone. Asking for perspective, that's where the elephant picture is great. And, we do this a lot of times with patients, and we want to continue to do it. Like, did I hear you right? But we also want to make sure that we're checking in with our teammates, right? Like, I heard you say this, is that like what you were intending? As supervisors, as leaders, we want to be asking our direct reports, like not assuming that we got it right, but saying like, hey, did I get that right? Is that what you were wanting me to hear? And again, very quick, something most of us are probably well practiced at in our clinical practice, and we could really easily transfer that to all areas that we work. Words matter, right? Trying to be very mindful of not only how I talk about people while I'm at work, but also in my personal life, not using jargon. And one of the groups that we use at Karen is called Trauma in the Brain. And the first part of the group is really looking, like they get a page that has all of those labels, those pejorative labels on there. And we ask them, like, how do they relate to those words? How have they used those words to describe themselves? And how are other people using them? And then we go on to teach them about like the coping adaptations that happened in response to a traumatic experience, and how it was quite brilliant because it helped them to survive. It has had, over time, it has become less effective. But honestly, also how the brain gets involved and the neural pathways rewire as a result of trauma. But just thinking about that in your day-to-day work. This is a huge slide. What I'd like for you to take away from it is the goal is compassion, satisfaction. And then the continuum really is fatigue to burnout. And as we talk about resilience and all those factors in the next couple of slides, thinking about once somebody gets to burnout, we've probably waited too long. Like once one of us in our career is at a place that, we're at that point, we missed a few steps around self-care, resilience. And I love this image, the steps, right? The idea for resilience is that I'm trying to stay a step or two, or in a perfect world, above that mossy part, that those steps can actually predict where the stress level will rise to, right? So I can respond to adversity, to stress, but it doesn't take me as long to bounce back from that. And so I think it's something that you can work on, just like aerobic ability, and we really need to prioritize it. I mean, I say it's no longer a luxury. I don't know that it was ever a luxury, but I think in the last few years, we can tell that not only for the people that we treat, but also for each other, like resilience is really a priority. Taking care of ourselves, it looks different for different people, and it's really important to reflect on what that's going to look like. You know, you can have physical self-care, emotional, social, spiritual. It could be nutrition, friends, coffee with friends, you know, exercise, sleep, mindfulness. I picked up Legos. I got introduced. I never did them as a kid. I picked them up when my 8-year-old was much younger, and he stopped liking them, but I like them. So I've continued to use them. I borrowed this from a presentation that was done last week. So Barnett and his colleague did a presentation through APA around self-care and wellness, and I kind of changed some of the wording, but this is something I think would be really cool. And again, you can do this for your patients, but we're only as good at treating as we, you know, take care of ourselves, right? It's the reason why, and this is like the old adage of the oxygen on the plane. Like the mother or the parent or the adult puts it on themselves before they try to give it to anyone else, because they're no good to anyone if they're depleted. So self-monitoring, like really thinking through the emotions and reactions that you're having. Like, what do you need? What do you need to be successful? What do you need to be doing your job well? Warning signs for fatigue, you know, what does that look like? And some of those warning signs I have on a list that at some point we could share if, you know, people are interested. What's working? What do you find enjoyable, relaxing, and rejuvenating? When are these things accessible, and who do you do them with? What's missing, right? Like where do I want something new? What's difficult? Why is it difficult? What's easy? Why is it easy? And then what can I change, right? Are there maladaptive coping strategies that I fall back on? And, you know, how can I maybe change those? My favorite is, what don't you control in your personal professional environment? The serenity prayer is incredible for so many things, right? But yeah, it takes courage to sometimes do what I can in a situation that I have control over. It also takes like a great deal of like acceptance and willingness to let some things go that I don't have control over. But those things, if I can let them go, will not be kind of depleting my tank and my resilience and kind of staying with me over time. This is just another great thing that you can try, right? Thinking about nourishing versus depleting activities. You know, and it looks different for each person. So let's say, for example, I know certain tasks of my day are nourishing, and I know certain tasks of my day are depleting. I might try to fill it with different things. I'm usually at my A game at 8 o'clock. So you guys are already getting me like halfway through that A game. I'm not there anymore. But so I try to get the things that maybe are depleting or that are going to take more mental energy done earlier. And then the things that are nourishing or more easily accessible, I might plan for another part of the day. It's also great when you think about going on vacation, right? Like if people are going to be covering work and some activities are nourishing for them, then maybe that's what we provide. Like we try to think about it that way. It's not going to work perfectly, but if somebody likes group therapy and you have a group, maybe it's great if that person picks up the group therapy, and maybe somebody else likes the family calls and is willing to step into those. Another thing that could happen, which is unrelated to what's nourishing or depleting, like, you know, kind of changing tasks, but more so in supervision and team conversations, you can really be like, ask your group, what's nourishing for you? What's depleting? Why is it nourishing? Why is it depleting? Maybe if something is depleting for me, when I hear how somebody else is looking at it and why it's nourishing to them, I'll gain a new perspective that could help me do the job better and make it a little less draining for me over time. These are just a list of professional wellness. I think one of my favorite things to consider is asking for help. Be smart enough to know when you need help and brave enough to ask for it, right? That takes a lot of guts. And it should be celebrated, even if it's hard. Like, even if, you know, I have a large department, or not a huge department, but I do have a department of 10 to 12 people under me. Sometimes when they ask for help, you know, it's kind of like, oh gosh, like, but I want them to ask for help, and I want to figure out how to make it work, because I want to retain those people. I want them to stay with us. Recognizing our humanity. You know, Amanda said something before everybody joined about like, we're all doing the best we can, right? Isn't that just the best way to look at us all? And then it takes a little bit of that edge off when things aren't going well, like that, you know, we're fallible, that, you know, we make mistakes, and, you know, that we really are just trying. And it can just take a little bit of that tone out. And it also will reduce, if I'm frustrated with someone and I think about like where they're coming from and all of the things that maybe they'll have going on, it immediately takes kind of that anger and frustration out. This was an app that it's in the free domain. It's in the public domain. You can get it for Android or iPhone. It's not Karen. It was something that was showed to us through the National Council. That R is the app like logo. So if you put in provider resilience, you would see that. It has some scales that you would fill out to kind of measure your resilience rating. One of my favorite things, and probably some of you are going to go like, oh my gosh, is time since your last vacation. Like put it in there, see how long it's been, and maybe plan something for yourself. Because in the end, if you want to think of, I mean, there's lots of ways to improve performance, but Schiraldi and his group at University of Maryland have done some research in this. And when you do resilience, sorry, my slide got a little messed up there. When you do resilience training, you know, things improve, happiness improves, self-esteem improves, and performance goes up when health is good, when people are happy, and when they're coping well. So again, sometimes we wonder, like we know why we do this for the people we care for, like treat, but sometimes we wonder why we're doing it for everyone else. And this is why. And probably one of the most important slides on this, and it's the last slide, so I think I'm going to make it in under time. That's a victory in and of itself for me. But the outcomes associated with the TIROC initiative. So, and this is like throughout literature, it's throughout a lot of research, even some that's come out in the last like few years, 2019, 2021. There's a decrease in critical incidents, seclusion and restraints, staff turnover. We need to retain staff probably more than we ever have, at least in my life. Staff use of sick time, staff injury, and that top-down power wielding approach, right? That's all reduced. So there's more collaboration, there's more mutuality. And there's an increase in engagement in services, positive health behaviors. So those are more for patients, but we also then see for staff satisfaction, there's an increase in staff satisfaction, better management of our own life stress, and people are empowered to approach difficult topics. And that was probably one of the most rewarding times during this whole process. I mean, there have been lots of rewards, but one time when somebody said, like, they were a part of our implementation team and they simply said, I had an interaction last week with someone, I didn't like the way that they were speaking to me. In the moment, I didn't know what to do. Like, I knew I was feeling off about it, but I didn't do anything about it. But this week I went back to them and talked to them about it. Like, oh my gosh, like if we can start seeing more of that, our systems will be so much better to work with them. Clients express more satisfaction, patient perception of staff competence. Like if we're taking care of ourselves, if we're well trained, like by golly, patients think that we can do our job well. And I know for me, when I was less competent in certain areas, when I didn't feel like I knew what I was doing, I was a lot more at risk for burnout than I am now, because I can treat them effectively and actually see some change. People get better. Clinical outcomes, so treatment retention, so people stay in treatment, they successfully complete, and they're more willing to accept next level of care recommendations. And so I think that's all for me. You'll see my citations there. And I guess now we're going to turn it back over for questions, but I appreciate this time with you all today.
That's right. Thank you, Dr. Tipton. This was amazing. I know there's been a lot of chat in the chat box, and I think a big takeaway, not just for myself, but where I saw a lot of action in the chat, was about safety and how important that is for the patients, for staff, for anybody, any living, breathing human. Safety modeled in any relationship anywhere is so important. And there's been a lot of talk about that. It's so relevant. It's always been relevant, but you know, we're talking more about it today, which is great. So we'll jump right into some questions. We might not get to everything, but we'll do what we can, and then we'll follow up with any additional questions after this presentation. So the first one came in actually before the webinar began. Please tell us how this approach can help people who are so traumatized that your entire focus in therapy is based on establishing a safe relationship and they're not open to doing any particular techniques.
Yeah, I mean, that is one of the challenges, because if you are going to be working with somebody who becomes that dysregulated, first of all, we don't want to set that off too early, because we want people to access treatment. But once they're here, some of that evidence-based treatment is around that phase-based approach. And the first level of treatment is really focusing on safety and stabilization. And there's no discussion of the details of trauma. So it really focuses on education. It focuses on self-diagnosis. It can be a lot less, like it can make somebody feel a lot less vulnerable and at risk than some of the other more intensive therapies like cognitive processing therapy, EMDR, prolonged exposure. So I would just say that it's really looking at how can I help someone to understand this, because as they develop self-compassion, as they begin to understand it as survival, and maybe it is a coping adaptation that's not working any longer, some of the meaning that they made around those events decreases, like some of those horrible things that they probably think about themselves. And over time, they might be more open and willing.
Absolutely. Absolutely. Next question, please tell us how to apply this to the adolescent population for a substance use disorder diagnosis with a mental health secondary diagnosis.
I think so. I think it is helpful when you can kind of keep people at the same, like within their peer group, gender separate. I will say this though, when we first started our trauma services here, we actually did it based on gender, and we did have adolescents, young adults in our adult programming. And sometimes it was helpful, sometimes it wasn't, but I think it seems to be best when they can relate to one another. And then I don't know that much changes about the interventions. I mean, if even at an adolescent stage, first of all, it's really kind of making sure not only that they feel safe in treatment or wherever you're working with them, if it's an outpatient session, but also increasing that sense of safety outside of that treatment. Because you can't really address trauma too well. More it's getting out of it if the traumatic things or the adverse events are still going on. And that's for really anyone. But beyond that, it's kind of thinking through, like, what are the coping adaptations? Because sometimes we see them really come up, especially early in treatment, around that population, right? There's just, there's already this like underdeveloped or, not fully developed brain. And then you have this substance use that, hijacks the brain. And then you have the rewiring of trauma. So it's really kind of identifying what the priority is and including that person. These kids don't get the opportunity to be asked like where they want to start, right? So maybe sometimes it's about asking, but beyond that, then trying to identify what they need for safety, stabilization, trauma focus, and throughout the whole thing, you're kind of integrating so that they're being prepared to kind of go home at the end of your hour session or leave treatment at the end of 30 days or whatever that looks like.
Perfect. Thank you. Can you explain the top-down versus bottom-up clinical approach to substance use disorder versus trauma and how those are integrated when working together?
Hoping I understand this well. I think of top-down as kind of like hierarchy in like organizational systems. I almost wonder if the question, and again, if I'm getting this wrong, please let these people know and they will like ask me to clarify. But what I think people are talking about is like, how do we treat, these? And really it is sequential. I mean, there was a time where everyone, I don't think it was just Karen, even since I've been here, and I've been at Karen 15 years in September, where people thought like you had to get somebody sober. And then once you got them sober, you could deal with everything else. Well, the thing is like everything else doesn't go away just because someone's sober, and it keeps creeping up and it's hard to sustain long-term sobriety. So treatment really has to be sequential, prioritizing both and kind of keeping an eye on both throughout the process.
Right. That makes sense. Okay. And now some of our live questions that have come in. Is our ability to repress the emotions of past trauma diminished as a result of age progression?
I think I would imagine that, in some ways. So I would think about that two ways. You really put me on the spot because that's a good question. I would be really worried about the avoidance. So one of the things that we know about trauma is like one of the symptoms is avoidance. So sometimes I'm not sure that we're actually like doing better, kind of like maturing out. It might be that we're better capable of utilizing, avoidance strategies. And so we don't see the effects of trauma as consistently until someone has to slow down. So I think that's where I'm going to leave it for right now. I don't know if I answered the whole question. So I don't, because I don't know how it looks as far as like maturing out of trauma. I'm sure actually, as you have corrective experiences, now that I'm thinking about this a little bit more, like corrective experiences in relationships, as you experience like kind of like that sense of safety and you begin to understand things better, sure, that's going to have a huge impact on kind of the way that you live and function within your life. And I would also want to be thoughtful around, is there a chance that there's underlying avoidance here? And if so, then that might not necessarily be supporting wellness and well-being around trauma recovery.
Sure. Yeah, that's very true. And on kind of we spoke about adolescence before. So on the opposite end of the spectrum for older adults specifically, the question kind of in here around repressed trauma, but it was more of a comment leading into a question. I wonder if the issues were coming up as they've accomplished life tasks, meaning the trauma is coming up as they're accomplishing their life tasks. And perhaps because of that, there's more room for trauma to ensue in older adulthood. How do you think about that? Is that something that we've seen at Karen?
So I'm not as familiar with that. In the very small like the very small group of older adults I've treated personally, again, I think life sometimes can, kind of take over and we become successful and we do really well. And even some of those like coping adaptations are helpful. And then, over time, we're maybe less able to use them. They're less effective. Or like, if we look at Erickson's, I always go back to Erickson. If we look at kind of those dilemmas that he talks about, like as you get older, you're kind of looking at life. And you look at life and you process and you think about your impact and you think about the impact of life on you, I imagine that, some of those things come up for people. So I'm not sure why exactly it might flare. I think, there's the possibility. So I wish I had a better answer. It's probably the best I can give you right now.
Sure. No, that's perfect. I think we have time for one more. We have a handful more questions that came in, but like I said, we'll get to them by email or, connect later. But for our last question, is there a spectrum of trauma such as moderate, severe? And if so, does treatment reflect that?
I have, no, I don't. So, again, I'm a psychologist, so I kind of fall back on my diagnostic manual. And so some people might be going, I kind of I don't look at it that way. So what we don't want to just look at the trauma itself. We want, again, because it's not just an event or an experience, right, of it. It also has to have effect. So it can't just be the symptoms. It can't just be, it has to give them an experience like that's overwhelming, and there has to be an effect. Right. So we treat trauma symptoms, not the trauma itself. Bad things happen to people sometimes, and the human condition is one toward resilience, which is pretty incredible. I tend to lean more toward looking at things from like that lens, right? So if I'm seeing things like avoidance, if I'm seeing the cognitions, the negative cognitions, the arousal type symptoms, the intrusive type symptoms, then I'm trying to figure out where it fits. And then I fall back to my old DSM. And, if there's no specified event, I go for the unspecified trauma related disorder. If it's specified, but it doesn't meet criteria for PTSD, I go that route for the other specified one. And then obviously there's the PTSD. And I will often do a disclaimer of with developmental symptoms or with developmental and complex related trauma related symptoms.
Sure. No, thank you so much, Dr. Tipton. We are grateful for your knowledge and your time today. This was a really good good presentation. And I know you just went high level. We could dive into so many of the topics that you spoke about, and maybe we will in future presentations. So thanks again. And thank you to everyone for attending. As a reminder, this presentation was eligible for 1 CE. We will be sending out a link to this recorded presentation and a PDF of the PowerPoint for you to review at a later time. And just remember, watch your email for a link from CE Go to complete your eval. Just a quick reminder, we have an exciting training coming up on April 21st. Karen is hosting an in-person ASAM Fundamentals of Addiction training. It will be from 8 a.m. to 5:30 p.m. on Karen's campus in Warnersville, Pennsylvania. Attendees will receive 8 CE credits and the cost is $185. So if that's of interest, you can visit us at karen.org/webinars for more information and to register, or you can reach out to your regional resource director from Karen, certainly about the ASAM or any other questions you have about Karen or any of our programming. We're happy to help. So thank you again for joining. We wish you a great rest of the afternoon. Be well.
Take care.